Getting old is no joke. All right, so we're live. We'll wait a minute for folks to kind of find us, jump on, etc.
Okay.
My cup.
I bought a bunch of those for the office.
I don't have a shirt though.
We got shirts, we got cups, everybody, and then I had my one of my staff hot pressed our office logo onto the sleeve.
Hey, nice.
Mm-hmm.
Super. All right. Well, what time do you have? What time is it?
10:59.
Okay. You guys are catching up because mine only says 11 now. Let's catch up over the course of the day.
There you go.
All right. We hope some folks are joining us. For folks that are joining us, feel free to type in questions in the comments. We'll try to get to questions kind of towards the end. We have some good information to share, some resources to share that we hope will be helpful. All right, I think I have it as 11:01, which must mean it's 11, so we'll get started. So hello, my name is Greg Ayotte. I'm the Director of Consumer Services for the Brain Injury Association of America. So part of my job responsibility is to respond to the requests that come in through our National Brain Injury Information Center, like our 800 line or our website. And one of the questions we get, certainly on a pretty regular basis, is questions around pseudobulbar affect. So we thought we would bring in an expert to talk about pseudobulbar affect, what it is, describe it a little bit, maybe some tips for families and caregivers, and some resources that could be helpful in understanding the issue and finding appropriate care. So we're very, very happy today to have Dr. Greg Oshanek with us. Dr. Oshanek is the medical director for the Center for Neurorehab Services in Richmond, Virginia. He holds board certifications. I get this list. There's a lot, right? The board certifications in brain injury medicine, behavioral neurology, neuropsychiatry, psychosomatic medicine, and general psychiatry. He's authored many publications, co-edited several textbooks. He was the initial national medical director for the Brain Injury Association of America, named that in 1996. He stepped down from that in 2010 to become chairman of the board for BIAA. He has continued to support our efforts. And we are very happy to have you here today. So, Dr. Oshanek, let's just start with what exactly is PBA, or pseudobulbar affect?
Well, Greg, thank you. I really am honored to be here and to be able to share this with the folks out there. Pseudobulbar affect, and I am not going to say that term over and over again. I'm going to say PBA. It'll save us at least 20 minutes in this dialogue. PBA is not a psychiatric disorder. I'm going to say that one more time. PBA is not a psychiatric disorder. PBA is a neurologic disorder. It arises following a neurologic event, traumatic brain injury, acquired brain injury, stroke, Lou Gehrig's disease, amyotrophic lateral sclerosis, MS, Parkinson's, Alzheimer's, other forms of dementia. It is a change, a breakdown of the brain's ability to send signals back and forth to the cerebellum, which is a part of the brain in the back part of the brain. Normally, we think about it controlling balance, controlling the smoothness of our movements, from getting a spoon to our mouth, being able to control our balance as we're walking, things of that nature. In this situation, what occurs with PBA is a loss of the ability to moderate or to dampen emotional expression. And so just as the cerebellum controls your motor movement, reaching for something, and as you get closer to it, you shake, 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 shake. Similarly, with your emotion, as you are expressing an emotion or as there is some emotion that is occurring, whether it's irritability, whether it's laughter, whether it is a dysphoria, sadness kind of thing that occurs normally, it becomes, the amplitudes become greater. And so what are termed pathological laughing, pathological crying, and you can even see in some situations pathological irritability. So it is not a depression. The individual mood wise, emotional, doesn't feel depressed. They don't feel despondent. They don't feel joyful when they're laughing. They don't feel truly irritable and angry. It is merely that loss of control of the fluctuations.
That's a fantastic explanation. And I just will reinforce what you said initially. It is not a psychiatric diagnosis. That is probably the number one piece of info that we like to share with folks who contact us. Are there time frames after an injury where it might present? Is this something that presents really early or later or both? Or
There's a number of different time courses that we can see. In looking in my practice, in even individuals who have sustained concussions, one can see some changes in terms of that type of emotional dysregulation, even in the first couple of weeks. Many times we see that in our adolescent patients, and we see that, we think of it as, oh, well, it's just a more of the same with some of teenagers and some of their emotionality, when in fact it's probably more similar to this type of PBA phenomenon. More typically, we see it occur later on in the course. And it's been estimated that 48% of individuals with traumatic brain injury at some point will have PBA, and 28% of folks with stroke will experience PBA. It's far more common in things like Lou Gehrig's disease and more type of Alzheimer's.
Mhm.
But clearly, you're talking half and over a quarter, half of people with TBI and a quarter of people with stroke. You can also see it in other types of more subtle forms, because to some degree, there is an ability for individuals to inhibit it. And if they are getting adequate sleep, adequate exercise, nutrition, hydration, those kinds of basic things, they can contain it. But it takes massive amounts of energy to do so. And in that regard, they can do it for brief periods of time, but then there's no resources left for other types of activities. And it robs from their ability to engage in other types of activities.
Yeah, I mean, we see that a lot, right, with many issues after an injury, where you only have so much cognitive energy, and if you're spending it all kind of filtering or managing one symptom, it's not much less for much else. Is there I don't want to say typical, but is it so when folks have these episodes? Is there a typical like time frame? Are these things that last like a minute? Can they last hours? Is it very variable from person to person?
They're usually very brief. They're usually sudden, They're described as being almost explosive in terms of how they occur. Um, they're almost, if you will, seizure-like in terms of boom, occurring.
That's exactly as you're describing that. It's exactly what I thought of. I'm like, well, it sounds almost like a pseudo
And
activity. Like,
and there's not even a, like with seizures, sometimes you may have an aura, you may have some sort of prodrome that lets you know. It's more like a flash. There's not a warning. Sometimes there are things that you can predict will set them off. I remember one junior high school teacher that we took care of, who would be in front of his class and would be lecturing, and all of a sudden, and he couldn't control it. And it would be no particular topic, no particular word or trigger. And it was debilitating for him in terms of being able to engage. So it would happen. It's generally short lived. It generally doesn't go on and on and on and on and on. And generally, people are ultimately get back to their baseline. So it occurs, it spikes, and then it gets back to their baseline. So it's not like they get worse after the end of it.
okay. So, are there suggestions for family members that are dealing with this? Like, it's it's very difficult for the family, I think, often to kind of wrap their head around what exactly is going on. And even when they start to understand it, they're not sure what should I do. Like, if they start to have this episode, what's the most helpful uh, response or support that they can offer?
The first thing to really help from a family standpoint, from the individual standpoint, is to not automatically label it as being psychiatric in origin. People, will start wondering if the person is profoundly depressed, if they are um, so behaviorally inappropriate, so impaired with their frontal lobe reasoning skills and their understanding of social context that they laugh inappropriately at things. They'll be at a funeral and they'll laugh inappropriately. And it's kind of like, well, what's wrong with this person? Why are they so frontal lobe impaired that they can't control and comport themselves? It's not a psychiatric issue. It is something that will have a trigger at that the family might be able to identify and discern. And again, many times it's fatigue driven. Many times it is um, stimulus driven to the extent that there's too many stimuli. There's too many things going
Mm-hmm.
on simultaneously, and the person is overwhelmed, and their systems um, of being able to contain it are too overwhelmed. And so planning and anticipation in those situations on the part of the family, on the part of the individual, are absolutely paramount. It's also critical to not make the individual feel embarrassed by it. They feel embarrassed enough. They feel out of control enough. But to say, pull yourself together, it's not going to happen.
Yeah.
Um, Nobody has ever been able to control their PBA by being told to. And, trying to embarrass them into behaving is not going to work. It may be helpful to help reduce the stimulation, saying, gee, maybe we need to step outside and just kind of collect ourselves or change the situation to some degree. It's also important to recognize that ultimately the individual may end up isolating themselves more and more because of that social discomfort. And that becomes a problem, especially when it occurs in parents with children, because they shy away from encounters with teachers. They shy away from encounters with the parents of their kids' playmates. They shy away from other things that are vital for parents to be involved in. And that creates problems. So there needs to be some assistance from the non-injured partners in these situations to help encourage them to engage and to watch for secondary depression, because you
Yeah.
can develop a secondary depression.
Yeah.
Even though this isn't a psychiatric disorder, it can create depression, it can create embarrassment, just as somebody who has a disfluency, as a stutterer, can develop depression and then withdraw.
Right. As folks that we talked to on the helpline would say, that it's kind of walking around the whole time waiting for the other shoe to drop, right? And if you're
Correct.
walking around like that all day long, and like I said, you're holding a lot of cognitive energy onto that, it's exhausting, and two, you're right. They'll isolate. They'll
Yeah.
just be like, I don't want to deal with that stress and anxiety, so let me limit my exposure. Yeah, and that can
Yeah.
definitely create some secondary kind of psychological issues: stress, depression, anxiety.
Sure. And it can create alienation between the partners,
Mm-hmm.
because sometimes these inappropriate laughters and inappropriate crying happen during periods of intimacy. And, if you're in the midst of being frisky and all of a sudden you start laughing inappropriately,
Yeah.
that doesn't make you very attractive to your partner, and that can create some issues in and of itself.
So if a person is is experiencing these episodes, what are one of the challenges we certainly hear about is trying to uh, how to explain it to professionals, right? So they go to their doctor, the primary care, whoever it might be. What are some tools or resources that the person with the injury or the family can use to help kind of talk to the professional in a way that will kind of move them towards appropriate treatment and not just being diagnosed as being depressed or anxious?
Sure. Well, I don't know if I've told you this story before, Greg, but I've been treating folks and been in brain injury medicine for over 40 years. And when all of this issue of pseudobulbar affect started, I was kind of saying, well, not in my practice. I don't see much of that going on.
Mm-hmm. Mm-hmm.
Or if I see it, I treat it. And there is a specific scale called the CNSLS, which is a lability scale that was developed specifically for research purposes. There's a copy of which in the self-advocacy packet that BIAA has stood up for folks. And so I took it and used it with 20 consecutive patients of mine in the clinic, thinking, yeah, I'm not going to find it.
Right.
18 of my patients scored
Wow.
positive for PBA. And I was going, missed it.
Yeah.
And so, again, being very chagrined and realizing that that it was far more common, even with my perspective and my vigilance, than what I was thinking and what I was observing or asking about. The first thing is, don't take anything for granted. And the CNSLS is a well-researched instrument for identifying the presence or absence of PBA. And as a family member, as an individual who may be experiencing PBA, use that rating
Mm-hmm.
scale. And if you score over 13, then you really need to take that in with you and
Right.
talk with your physician, talk with your physician, your nurse practitioner, your PA, whomever you're getting your care from, and discuss with them the presence of this. In the old days, we used to think that you could use a specific serotonin reuptake inhibitor,
Right.
amitriptyline,
Right.
something of that nature to make a difference. And to some degree it did, because what we were treating was the depression that was secondary to it. And it would make a difference. But we have a whole different perspective and a different approach now that is a far more targeted, neurologically based approach for PBA.
Um, So I'll also share that on our website. So the on our website, it's www.biausa.org/PBA. There's some information about PBA, and then on the right-hand side, there's a toolkit, an advocacy toolkit that folks can download and use. It includes the CNSLS that folks can use and fill out and share with their provider. It includes a log of episodes, kind of when they happened, what the symptoms were, how long, what was going on. So those type of things can be helpful in sharing it with the provider. What I usually tell folks is if you can have something more than just written down, here's what I'm experiencing, like this is the language of clinicians, right? If you give them the CNSLS, you're like, oh, okay, this is what I speak. It helps to turn that conversation enough to at least, if you can get them to ask the question, could it be this? That changes the conversation versus just coming in and saying, doc, I'm sad or crying or laughing at inopportune times. And so the toolkit can be helpful in kind of shaping the conversation with the provider, because we know often if you're going to like a PA or a primary care doc, it's not likely they'll be familiar with the condition. So kind of speaking their language a little bit can certainly help. Are there particular types of doctors that are more likely to kind of be familiar with this?
One would hope. I was hoping I was familiar with it. It in general, one hopes and one would expect that neurologists, physicians that are board certified in brain injury medicine, absolutely. There are now only 1,200 of us across the United States that are so board certified, but clearly all of us are very well versed in this. Individuals that are neuropsychiatrists, that are the MDs, not the PhDs, the MD psychiatrists are very well versed. More and more psychiatrists are becoming versed in this, not because this is a psychiatric disorder, but because this is a neurologic disorder that many people misidentify as psychiatric and send people to psychiatrists. And then they say, no, wait a minute, wrong. There are also rehabilitation medicine physicians, physiatrists that are well versed in this, and even sports medicine physicians, concussion physicians are both from a family medicine background or an internal medicine background are becoming sports neurologists are becoming more aware of this as well. It is something that with the average encounter with a physician being 10 to 12 minutes,
right?
Having an instrument where you've got a number and you can go in and say, my CNSLS is 18, and they go, okay, 18. It makes that's a shorthand that gives them a metric.
Right.
Makes it much more rapid than going through each and every one of those symptoms, and life so much easier for all parties concerned, especially when you've got a good relationship with your provider.
And I would think even at that point, even if they're referring you to somebody, psychiatrist, neuropsychiatrist, whoever it might be, that may not be as familiar, that's a different referral question. The primary care is now referring that person to, hey, this, they scored an 18 in CNSLS. Here's the score. Here's what's going on. That changes the conversation versus, they're emotional all over the place. We're not sure what's going. That's a very different referral question. So I totally agree. It's something that speaks the language of the clinician can help kind of turn that conversation just enough.
And to some degree, Greg, in this day and time, it may also permit the primary care physician to initiate therapy, because since there is a specific therapy for PBA, it may permit the first encounter to say, okay, let's try this, and let's see if the medication, New Dexta, makes a difference for for the individual, because within a 2-week period of time, 3-week period, you're going to see which way the wind's blowing and have a sense of whether there's going to be benefit.
Excellent. All right. So I'm looking to see if we have any questions that have come in. So one of the persons asked, in persons with epilepsy, can this be a comorbidity or misdiagnosed as a type of seizure?
Yes and yes. Again, depending on the cause of the epilepsy. Certainly, if somebody has post-traumatic epilepsy from traumatic brain injury, sure. One is going to also have diffuse axonal injury that can affect the cerebellar pathways. And to the extent that there is has been any kind of intracranial bleeding, and you've got then vulnerability for seizures, yes, then you can also. To the extent that there is any type of other stroke, to the extent that there's any other type of MS, Parkinson's, whatever, sure, you can see, as I tell my patients all the time, you can have fleas and ticks, and you can have both types of difficulties that occur. The other, and it's also easy enough to try to do a trial with new Dexta, that in the context that if it doesn't work, okay, fine. You're only doing a 2-week trial or a 3-week trial. So it's not like you're doing an extended period. You don't have to be on it for 6 weeks to know whether or not it's going to make a difference.
Okay, that's very helpful. Have any other? I don't know if we have any other comments, questions that might be around. So I can see that we had put in the comments the link to the toolkit. If folks that end up watching this are certainly looking for information on like providers in their area who might understand brain injury, they're more than welcome to contact us through the National Brain Injury Information Center. That number is 800-444-6443. You can call and speak to a brain injury specialist to get information about resources and supports in your area. Any closing comments, words of wisdom, advice?
I think the key issue is that if you identify PBA and if you have an understanding of it, the risk of feeling embarrassed, the risk of isolating yourself, the risk of feeling stigmatized by it is going to be less. And it is something that can be treated effectively, is something that in some situations is a transient process, especially in TBI, as a transient process. And so the treatment does not have to be an ongoing, lifelong commitment to a medication. It is something that is a stabilization kind of situation, and then people do better, and as they heal, move on. In some situations, other situations, unfortunately, it is a more permanent kind of lifelong. And in other situations, it's an intermittent that individuals during certain peak times, they will need to be on it. So there's lots of different patterns. It doesn't mean that it's like being on insulin for your diabetes, and once you're on it, you're going to be on it. So I think the key idea for everybody is to not fear getting it diagnosed, and to absolutely not let it be misdiagnosed as only being, quote unquote, depression, and it being psychiatric. It is neurologic. It is a consequence of neurologic dysfunction, and it needs to be addressed as such.
I think those are great words to end on. Thank you so much for taking the time to share your expertise with us today, Dr. O'Shea. Again, if folks have questions, they're more than welcome to contact us. Go check out the toolkit, download that, use that. Thank you again. Hope everybody has a fantastic rest of the day, and take care.
Always a pleasure. Thank you.